Day, everyone, and welcome to this web seminar, Understanding the Health Equity Barriers of GLP-1 Diabetic Medications. I'm Lynn Gresham, your host. In this program, we're going to talk about the use of GLP-1 drugs not for treating obesity, but for their original purpose, managing diabetes. With us are three experts from Merative, formerly IBM Watson Health. They're going to talk about how GLP-1s fit into diabetes treatment regimens and the socioeconomic forces impacting their use, from being underprescribed to having fair access to these popular prescriptions. But first, I'd like to introduce the panel to you. Catherine Shanahan, Senior Pharmaceutical Analytic Advisor, is a pharmaceutical industry expert who assists commercial and government payers, providers, and research teams in developing actionable pharmacy-related analytics, strategies, and programs. Her background in pharmacology, toxicology, and drug R&D enables her to help clients identify cost savings opportunities, improve prescribing quality, reduce misuse of medication, and lower barriers to treatment, making healthcare more affordable and effective for plans and patients. Brandy Hodor is a senior healthcare analytic advisor at Merative. Brandy has over 2 decades of healthcare strategy planning experience and is an expert in the integration of socio-demographics and social determinants of health data. At Merative, she oversees a cross-functional team with capabilities to deliver analytics and innovative solutions in both traditional and value-based care arrangements. Rounding out the panel is Becky Nias, Senior Healthcare Analytic Advisor. Becky has over 15 years experience working with healthcare data in data management, product management, and analytics. She has worked extensively with employers to identify population health savings opportunities, measure outcomes, and recommend future strategies. She collaborates with other industry experts to develop an analytic approach to address healthcare challenges, such as cost containment, health equity, and provider variability. Ladies, welcome to you all. Catherine, I'll now turn the program over to you.
All right, thank you. Welcome, everyone. So I'm Catherine Shanahan. I'm a Senior Pharmacy Analytic Advisor here at Merative. You may know us under some of our former names, IBM Watson Health or Truven. We were purchased by Francisco Partners in 2022 and bring over 40 years of expertise, methodologies, and data assets under this new name as a healthcare industry leader. Our 4,500 customers span the healthcare ecosystem, comprising of 40% of Fortune 100 employers, 7 of the top 10 health plans, and over 70 state, local, and federal government agencies. So this vast experience and knowledge of the healthcare ecosystem is funneled into our products, such as Health Insights and Market Scan, which offer a no-code approach to understanding your population's trends, measuring outcomes, and identifying actionable insights. These tools allow you the flexibility to either roll up data to like an executive level dashboard or all the way back down to patient level care. So today, we'll be walking through insights generated from our Health Insights platform using Market Scan data. Becky will talk a bit more about Market Scan later on in the presentation, but for just really briefly, Market Scan is the largest national data set of U.S. claims for healthcare research with over 293 million lives. So, but first, I want to kick it off with some background of GLP-1s, which I know most of you are probably very familiar with at this point. But let's start off with a couple poll questions to better understand how you all are managing GLP-1s with your benefits. I think you're on mute.
Thank you. Excuse me. The first poll question we'd like you to weigh in on is, do you cover diabetes-specific GLP-1s on your formulary? For example, Ozempic, Trulicity, Victoza, etc. The answer choices are yes, no, or I'm not sure. Do you currently cover diabetes-specific GLP-1s?
And just to be clear, we are splitting the diabetes specific and the weight management up here. So this is diabetes specific. I know I've said that a couple times. I know get a little mixed up, and sometimes, especially when you're focusing on the weight management too.
Thank you, Catherine. We do have a large group on, so I'm going to give it several seconds for the votes to come in. Be sure to hit the submit button. Thank you for your responses. Okay, Catherine, let's take a look at these results.
Yeah, they're as I would expect. Most plans are covering diabetes-specific GLP-1s, and I believe that, when we talk about benefit changes and wanting to manage GLP-1 spend, I think for a lot of payers, it is these diabetes-specific GLP-1s that are the most challenging, and so that's really what we're going to focus on today. But we do have one more poll question that we wanted to ask about this.
And it is, do you cover weight management GLP-1s on your formulary? This is specifically weight management GLP-1s. Yes, no, or you're not sure? The results are still coming in. I'll give it a couple more seconds and then we'll take a look at the results. Now we're pretty evenly split. Is that what you'd expect, Catherine?
It is. Weight management GLP-1s are a bit more, I don't want to say controversial, but I know different payers are having different strategies as it relates to these. Some are using weight management medications, and the coverage of them is part of their benefit package, part of their tools to attract, talented members and wanting to bolster, their employees, and as well as long-term strategies for better health within their populations. Others, it's just quite not in the budget. These are really expensive medications. And we'll talk a bit about kind of the differences there, what, especially those payers who are not covering weight loss medications, these weight management versions, what that means potentially for off-label use. And so we'll talk a bit more about each of these kind of subjects as we go forward in this presentation, but this is really helpful. So not surprisingly, as I'm sure, again, a lot of you know, diabetes prevalence is growing really substantially across the United States. So back in 2004, most regions of in the US, the prevalence rate for diabetes was around 3.3 to 6.5%. However, by 2019, this grew to a rate between 10.1 to 19.5% of the population. That's 3 times the prevalence rate in just 15 years. And so with that increase, we also saw the treatment landscape for diabetes expand, right? So since 2004, when we first looked at the last chart, we've seen the entrance of 3 new drug classes to the diabetic treatment landscape: DPP-4s, SGLTs, and GLP-1s. Given their increased efficacy and reduction in side effects, these 3 new drug classes have begun to kind of replace older classes that we saw previously. So like your TZDs or your sulfonylurias. So in those, in the diabetic situation where they're higher severity and they maybe need combination therapy, either dual therapy or triple therapy, we're seeing the newer classes, DPP4s, SGLTs, and GLP-1s being used in those combinations now more frequently than like your sulfonylureas and your TZDs. And we're even seeing, just to mention too, that we're seeing a shift back of insulin is the other. Insulin is generally now being used either for if there's cost barriers or in higher severity cases, again, with the priority being emphasized of these newer drug classes. And so this shift from older drug classes to newer ones, we're seeing especially GLP-1s are standing out even above the DPP-4s and the SGLTs because of their added benefit of weight loss for diabetic patients. So many physicians see this dual benefit of both insulin management for their current symptoms, but then also weight loss for that future prevention of disease progression as an important reason of why GLP-1s are being prioritized. And these grids, you can kind of see them towards the top, especially as dual and triple therapy. Especially for patients who have high severity cases where weight loss would aid in that reduction of diabetes related complications. And so later on, when Becky is showing some different graphs, we're going to look at those rates of diabetics with complications or high severity and how GLP-1 use varies across different populations. So here we have just a quick grid of FDA approved GLP-1s. As you know, I mentioned before, most GLP-1s are approved specifically for diabetes. However, obviously, there's 2 products that have expanded into weight management treatment. As you can see, many products share the same compound. So, for example, Victoza is a diabetic medication, Saxenda is weight management medication, but they both use the compound liraglutide. Likewise, semaglutide has 3 products on the market, so Ozempic, an injectable diabetic medication, Rybelsus, an oral diabetic medication, and Wegovy, an injectable weight management medication. So as this GLP-1 drug class continues to expand because of this priority in diabetic treatment, because of its expansion into weight management, we expect to see more compounds come out into weight management, especially there's one from Mounjaro right now, tirzepatide, that's being reviewed by the FDA. We also expect to see expansion of oral options. Right now, Rybelsus is the only oral GLP-1 that's available currently on the market. So to that point, as I mentioned before, GLP-1s are expanding over this last decade. So they've quickly become a staple for diabetes treatment and then expanding into weight management. And we see that reflected here in the cost and utilization trends market scan. So in 2013, GLP-1 medications were used by 4.8 patients per 1,000 members, contributing $13 in allowed PMPY or per member per year. This has risen to 28.3 patients per 1,000 and $184 PMPY. A compound growth rate of 22% and 35% respectively. So this 35% compound annual growth rate of PMPY spend is exactly why payers are starting to feel the sting of GLP-1s. They're really expensive. The average spend for GLP-1 treatment for patients in 2022 was nearly $6,000. And moreover, as GLP-1s have become recognized for their weight loss effects, especially in populations where we're seeing payers are not covering weight management options, we're seeing this increase of off-label utilization, contributing both to drug shortages for diabetic patients as well as higher costs overall for plans. In 2020, 13% of diabetes-specific GLP-1s, those users did not have a diagnosis for diabetes that year. But one of the biggest challenges that looking forward at GLP-1 treatments is adherence and persistence. So as with any diabetic medication or weight management drug, adherence is critical for the types of positive outcomes that payers, providers, and patients alike are expecting with these medications. Over the last 4 years, if we look at just the diabetes-specific GLP-1s, the average annual supply per patient hovered around 220 to 230 days, so about 7.5 months. But we see a stark difference in the average annual supply with off-label utilization. In 2021, GLP-1 patients with a diagnosis of diabetes had an average annual supply of 240 days or 8 months, compared to GLP-1 off-label users with an average annual supply of only 170 days or 5.5 months. But keep in mind, this doesn't include Wegovy or any of these new drugs that have come to market since then. So we're looking at medications that were available for the full calendar year, and we see really the stark difference between on-label and off-label utilization. So as you're planning ahead for your future strategies and benefit designs, we recommend taking a look at our guide for weight loss medications and GLP-1 coverage. We have a link to it at the top, and actually we're going to put one in the chat. This includes 5 action items that payers should consider and plan ahead for. And we really recommend this as a great, kind of how-to, great white paper on this exact topic. But next, I'm going to pass it over to Brady Hodor, who's going to give us some more information around and background information on the socioeconomic data that we layered into the analysis.
Thank you, Catherine. So the first thing as we think about social determinants of health is we had a quiz for you. So I'm going to hand it over to Lynn.
Thank you, Randy. Do you currently integrate health equity information with your claims data? The answer choices are no, this is not a priority for us at this time. No, but we plan to in the future. Yes, but only patient-level data points such as race, ethnicity, wage information, etc. Yes, but only from publicly available data sources. Yes, both patient and public data points. Do you currently integrate health equity information with your claims data? About a third of you have weighed in, so we'll give it a little more time. Give it a few more seconds. Okay, I'm going to close the poll and let's take a look at these results. 42% say it's not a priority, 40% say not now, but we plan to in the future. How would you like to weigh in on those results?
Yeah, so I'm hoping we can show you today some of the value of layering in some of this data. So I'm going to go on to the next slide, and I appreciate your feedback. So really, as you start to think about social determinants of health, they've really started to play a key role with the employers and health plans that we talked to, and really how they want to engage and advance that equity and kind of engage their members and their populations. And this is just as important when we start to think about these GLP-1 drugs that Catherine was just talking about. Organizations are looking to obtain the highest level of health for all of their members, but each organization is at a different square on the board in moving forward. So definitely think about that as we talk today. No two employers or health plans are in the same location. So as you start to think about some of the things that you're going to need to do, as you start to think about advancing health equity, really you need to build that business case. You need leadership buy-in. You need them to put this as a priority into the corporate health and well-being strategy. Kind of that next step is really understanding the data you have and bringing in new resources for data so that you can either collect the data you need or start sourcing it from outside locations, such as publicly available data, like we're going to talk about today. And really that allows you to start understanding access, utilization, outcomes, and really allows you to stratify your population and understand what's going on. We've kind of passed that point of, everyone's considered equal. And we're really down into the data and wanting to understand, hey, how do we engage those who need to be engaged, and how do we do that? And that leads us to the third pillar here, and that's developing that communication. This is one of those ways that employers and health plans are finding very easy to move that health equity lever. And as they start to think about what they can do, changing the communications and how they engage those members can really be that first step. And personalizing it for the specific populations that they're targeting, whether it's a population that lives more rural or is more limited English speaking, starting engaging these pieces of data into their health equity approach can start moving that needle forward. And then as an employer or a health plan, you can start developing policies and making environmental changes to kind of help reduce the barriers to access concerns across diverse populations, so that everyone has access to the same care and they have access to the same needs that they need. And then ultimately, by taking each of these pieces of data and kind of moving into that next realm, we have seen some employers where they're at that point where they're wanting to engage the community, because this is where the members live. This is where they engage with their healthcare resources. This is where they get that healthcare services, and where they have, such things as, food concerns or housing concerns, transportation, and so that they can really understand the communities where their members and families live and help move that needle there. So there's a lot of different ways to start doing this. And definitely, as you start to think about this, like I said, each employer, each health plan is at a different spot, and really finding what works best for them is how to move forward. And so as you start to think about data that you might need, we've brought some instances of data available here. And so we kind of need to step outside that realm of traditional health analytics. We need to think about what else do we have available. We've traditionally talked claims and pharmacy data. We want to really understand who are the people and why do they do what they do. What causes one person to go to their doctor visit every year and someone else to avoid those preventative care. So as you start to bring in data, one of the first pieces is that publicly available data is something you can think about. And that's what we're going to show you later on today. We're going to actually focus in on the Social Vulnerability Index, but there's a lot of other rich data sources out there in the industry, such as the ADI, the Area Deprivation Index, and other resources that can actually help you when you start to think about what are the communities where your members live. There's also a lot of resources around race and ethnicity benchmarks. So that's another level where you can start to bring in those benchmark data to understand, is your population measuring up to what we're seeing in other areas across the country? Really cool is with the turn to ICD-10 codes. One project that was started was the Gravity Project, and that was to target social determinants of health ICD-10 codes to be created. So they started thinking outside the boxes. For a while there, everyone was collecting data in their own way around social determinants of health, and they really wanted to kind of mainstream that and say, hey, when that patient has that face-to-face visit with a doctor, what do we need to capture? What do we need to know about the patient? And so some of it was captured in ICD-10 codes for social determinants of health codes, such as the Z55 to 65. There's also the lifestyle risk codes, which are the Z69 to 76 codes. And that also gives you a lot of deep information about your population. And again, this is person-level information that's being captured at that face-to-face visit with the physician. So around sleep, stress, burnout, tobacco use, concerns with financial issues, concerns with getting food and putting it on the table for their family. So there's a lot of data to go back to, and that's still evolving as the physicians get comfortable using those codes, but that's going to actually start only improving year after year. And then as you start about client-specific codes, what are you already collecting that maybe you haven't thought about using? Race and ethnicity obviously is something that's kind of come to the forefront as we kind of moved out of COVID. There's other data that's going to start to be collected, such as gender at birth or gender identity. So some of these other specific codes you may want to start to think about as you move forward in the social determinants of health pathway. And so today we're going to talk about the Social Vulnerability Index that comes from the CDC. A lot of you may be using this already or may have already heard about it. Basically, what they have done is they have collected information from the census data. All of the data is at the census tract, so it's not at that rooftop level, but we're going up to that census tract, which still gives us a lot of good granularity compared to other data that might be collected at a county level or a zip code. This data was originally collected to kind of understand when the government needs to go into an organization or into an area after a natural disaster, such as Katrina. What do they need to be worried about? And so you'll see there on those pink fields that we've kind of brought in for you, some of the different fields that are on this file. So understanding if an area is higher poverty or higher no high school diploma. Does this area have more kids? Does it have higher people over the age of 65? Or is it more crowded households? Do they have issues with transportation? So while this data gives you a good snapshot, it's a good just step in that first direction of understanding the community of where your members live. So by geocoding your members and bringing them down into that census tract, you can then start to understand what are the issues at that neighborhood level that they might be encountering. And so we brought to you an example today. This is a national employer. And so as you start to move, if you look at the graph there, you'll see we're looking at ER visits per 1,000. So we've brought something very simple from the claims data. We've mapped their members into their census tract, and then we've labeled them into 4 different buckets. Do they fall in the 0 to 25th percentile for being below poverty, if you look at that purple bucket there? Or do they go up to the 76th to 100th percentile for being below poverty? So those at 76th to 100th percentiles are those areas that are higher poverty. So as you move up and across, you get into areas of higher poverty across the country. And so you can see the trend that traditionally happens. As you move up, obviously we see more ER visits happening in those areas of higher concern. And this starts to make a lot of sense if you think about it. Areas of higher poverty, doctors' offices are not opening up shop. We don't get new ER clinics popping in or urgent care clinics popping in. Grocery stores don't move into these areas. These are concerning areas where we want to understand if we have a population living there. You can see we've also brought some of the other areas from the Social Vulnerability Index, whether it's the no high school diploma in red, the single parent households in blue. We've also brought in the minority. So as we move into areas of higher minority, we do see obviously higher trends in ER concerns. And then even over to the far right, via not having a transportation. As you move into areas with no transportation or with transportation concerns, they tend to go more to the ER. So not surprisingly, we see trends we expect here. And so even if we go back to what Catherine was talking about before, so again, we're looking back at diabetes today and what's going on. So here we've mapped it into those 4 different buckets based on the Social Vulnerability Index at that poverty level. So the 0 to 25th percentile all the way up to 75th to 100th. And so as you look at the 3 different pieces of information we brought to you, ER visits per 1,000 for diabetes patients in purple. The diabetes patients overall per 1,000 members in green. And then even the diabetes ER visits per 1,000 for diabetes patients. We see that trend we expect. As you move into areas of greater concern for poverty, we see those numbers start to increase. And so today, we're actually going to start to look at some deeper information. So I'm going to hand it over to Becky now, and we're going to take the Social Vulnerability Index and we're going to integrate it in with the claims data and see what it starts to show us.
Thanks, Brandy. As Brandy said, I'm going to review some of the data that we see on GLP-1 use and poverty in our market scan data. But first, we have another poll question for you.
Thanks, Becky. The question is, how do you think your member out-of-pocket costs compare for GLP-1s versus your average diabetes drug treatment? Would it be GLP-1s cost members less than the average diabetes treatment? GLP-1s cost members about the same amount as the average diabetes treatment? GLP-1s cost members 50% more? Or GLP-1s cost members twice as much as the average diabetes treatment? How do you think your member out-of-pocket costs compare for GLP-1s versus the average drug treatment for diabetes?
Yes, and as Lynn said, specific to the out-of-pocket costs, we know that plan costs are very high for these drugs.
That's a good qualification. Thanks. We've still got answers coming in. Thank you all for your responses. All right, let's close the poll, Becky, and take a look at the results. It's sort of a mixed bag. Did you expect that?
I wasn't sure how aware people would be, and I'll go into this in more detail as I go through the data. But we actually see in our data that GLP-1s cost members out of pocket about twice as much as the average diabetes treatment. We'll talk about it more, but definitely something that needs to be top of mind as we're thinking about health equity is how much not only is the plan paying for these drugs, but individual members as well. So Brandy and Catherine both touched briefly on market scan when they spoke, but I'm going to go in just a little bit more because the data I'll be discussing comes from market scan. So market scan's a fully adjudicated, de-identified, closed data set that we source from a diverse pool of commercial payers and plan sponsors. And the fact that we source our data from payers means that we can offer a really complete view of the patient journey. Market scan data includes several Merative proprietary groupers. And today I want to level set on disease staging because it's important to the analysis I'm going to walk through. So disease staging is a classification system that identifies diseases and the progression of those diseases. We originally developed it in 1983 with Thomas Jefferson University, and it's maintained in conjunction with them, as well as methodologists at Merative. In our study today, we use disease staging to distinguish between the severity of diabetes patients and how their treatment differs by that neighborhood poverty level that Brandy talked about. Disease staging is the basis of Merative's medical episode grouper, which is what I have used in the study to define diabetes patients. So for disease staging here, you can see that the lower disease stages of 0 and 1 correspond to pre-diabetic symptoms like insulin resistance and impaired glucose tolerance. And that highest disease stage corresponds to diabetic patients who have complications such as neuropathy and heart disease. For the analysis that I'll walk through today, we used claims incurred between April 2021 and March 2022, and we applied the neighborhood poverty level from the 2020 Social Vulnerability Index, and we mapped that to the zip code level within the market scan data. Okay, so let's move on to the findings here. Brandy showed earlier that care associated with diabetes increased as neighborhood poverty increased. And consistent with that, we can see that this red line, which is the percentage of patients with higher severity diabetes, the red line goes up from left to right on the chart as neighborhood poverty goes up. If we look at the bars, however, which represent the rate of GLP-1 use, so GLP-1 patients per 1,000 patients with diabetes, we don't see that same sort of trend. In fact, the lowest poverty group on the left has almost the same rate of GLP-1 use as the highest poverty group, which is on the far right, despite having a much lower percentage of patients with high severity diabetes. The gap in utilization that we would expect based on that percentage of patients with higher severity diabetes within that highest poverty group is really concerning when we talk about health equity, and it prompted us to dig in deeper into this data. So we drilled into the utilization patterns of the two most utilized GLP-1 drugs, which is Ozempic and Trulicity. And we chose to look at these two in specific because when we looked across all of those diabetes GLP-1 drugs that Catherine talked about, these drugs really dwarfed in usage what we saw for any of those other drugs. So when we look at just these two drugs, we can see that the highest poverty group has the lowest utilization for both the drugs, but we can see variations in the pattern of use as we see on the chart on the left. So the differences are small, but we can see for Ozempic, so the purple line, the lowest poverty group, so the wealthiest group, has the second highest rate of utilization across all poverty groups. And remember, this is despite the fact that that group has the healthiest patient mix, while we see that Trulicity use in the group is the lowest across all poverty groups, and it's actually lower than what we see for Ozempic, which is not true for the other groups. And when we look at the off-label use, so this is patients who have no documented history of having a primary diagnosis for diabetes, we see that the highest rates of Ozempic use are in that wealthiest population, and there's almost no variation between groups for Trulicity use. So we call this out just to say that as we're talking about GLP-1 drugs, not all GLP-1 drugs are the same. I'm going to talk about them as a group, but just know there are differences when we look between different drugs. So going beyond just the utilization rates, if we look more specifically at average days supply, which is one way that we can look at adherence through claims, we can see that across diabetes drugs in general, and for both insulin and GLP-1 medications in specific, as the neighborhood poverty goes up, that average days supply goes down. So GLP-1 adherence is not only lowest when we look at the total diabetes drugs, which we would expect because that's going to be a little bit higher because patients are on combination therapy, which will raise total days supply. But it's also lower when we look at a drug with a similar place in diabetes therapy like insulin. And one hint as to why this might be the case is if we look at that average out-of-pocket spend, which is significantly higher for GLP-1, so it's about $550 per patient on an annual basis compared to insulin, which is about $375 annually, and then compared to your average diabetes treatment, which is around $240. So that's $550 for GLP-1s and $240 on average for total diabetes treatments. So as we mentioned in the poll, it's about twice, actually a little more than twice, what the cost of an average diabetes treatment is. And so these out-of-pocket costs maybe are not significant to a member who lives in the wealthiest neighborhood, but it can be a reason, a potential reason for drug discontinuation for members who live in those highest poverty neighborhoods. So we're going to slice into the data a little bit further. We know that different industries offer different benefit packages, have different population makeups, and we wanted to look to see how that played out in terms of access to GLP-1 drugs. So if we look at the table on the left, we can see that even the industry that has the lowest percent of members in the highest poverty neighborhoods, and that's finance, we see that even there, close to 10% of members live in that highest poverty neighborhood. So even for those of you in finance, close to 1 in 10 of your members is living in a high poverty neighborhood. So even if you think you don't, you probably have members who are impacted by this. If we look at the chart on the right, it's sorted by the level of poverty in the industry. And we can see that while finance does have the highest rate of patients on GLP-1s, as associated with that lowest rate of members in high poverty neighborhoods, the lowest rate of GLP-1s is actually in the durable goods manufacturing industry, which doesn't have the highest poverty rates. So we do know that there's more going on than just the poverty level of the industry might be related to those different benefit designs. So if we look into industry a little bit further and split out members into those who are living above the 75th percentile of poverty and those who are below the 75th percentile for poverty within the neighborhood they live in. We can see that for every industry, the higher poverty members, and that's the right-hand bar in each pair. So the higher poverty members are more likely to have higher severity diabetes, which we can see in the top chart, but have less access to GLP-1s, as we can see in the bottom chart. So that's across the board. For the most part, we are seeing these patterns of higher severity and poverty, but lower access to GLP-1s. And then if we look again in nearly every industry, if we look at that potential off-label use, so this is the members who have no documented history of diabetes, we can see that across the board in every industry, the members in the lower poverty neighborhoods are using more GLP-1s than members in the higher poverty neighborhoods. So even if you think you're providing equitable benefits and equitable access, or for off-label use, equitable barriers to these drugs, it's really worth digging into your own data, into your own claims, to understand if that's really the case. So the last drill we wanted to look at was looking at the impact of union membership on GLP-1 usage. So we know union benefits tend to be richer benefits, but they may also be a little bit more frozen in time compared to those non-union benefits, in that the benefits will only change when there's a negotiation versus changing with what's going on in the market. So the next couple of slides I'll walk through are limited to only to employers that have a union population, but it does have both their bargained and non-bargained populations in these charts. So probably not surprisingly for people who've worked with union populations before, we can see in the chart on the left that the union population has a higher percentage of patients with higher severity diabetes across every poverty level. But if we look on the chart on the right, we see that union members actually have lower rates of GLP-1 usage compared to non-union, which might be a little counterintuitive because we think of unions having those tending to have richer benefits. And then additionally, despite having higher obesity rates, so that's the top chart, so the union members tend to have higher obesity rates, and this is in patients without diabetes. We actually see that the non-union population has more off-label use for these GLP-1s than what we saw in the union population. And we thought that this might possibly be because the unions had better access to weight loss, to the actual weight loss GLP-1s. So we dug into that data and we actually saw no difference between unions and non-union members in terms of their use of Wegovy and Saxenda. So these lower rates of utilization might very well be explained by frozen benefits for unions, which is just to say that for those of you who work with organizations who do have unions or do have unions in your own organization and you're going into negotiation years, it's possible that these GLP-1 drugs are something that's going to be brought to the negotiation tables, and you may want to be armed with some of this data. So with that, I'm going to turn back over to Catherine and Brandy to walk through some of our recommendations and next steps.
Thanks, Becky. So what does this mean for you all and your benefit strategies as you're looking forward? So first, we recommend analyzing how prior authorizations and those out-of-pocket costs may disproportionately impact lower-income individuals in your population that we know have higher rates of disease states and are likely more in need of GLP-1s, but potentially have that financial barrier. So when adding up all the out-of-pocket costs for a diabetic patient, does that $550 spent on GLP-1s create a barrier? Are there opportunities to offset copay assistance? Is there opportunities to remove out-of-pocket altogether for certain high-value treatment options, especially in the future if there are generic options? We'd recommend also considering how weight management programs may offer income individuals access to things like nutritionists or exercise classes that might otherwise be a financial barrier. And actually, that was one of the questions that we got in, is around if there are solutions that can help with the weight management in tandem with these GLP-1s. And truthfully, if you really look at the research done on GLP-1s when they are coming to market, right in the research papers, they talk about that these are not taken in silo. These are not replacements to exercise and nutrition. They are additive, and they are additive to amplify benefits, not necessarily to replace nutrition and exercise. And so those types of solutions and support solutions, weight management programs, there's lots of different point solutions on that. They really help not only improve that adherence, right? There's someone to help keep that patient accountable when maybe with the way that provider networks are right now, kind of strapped in terms of keeping a patient and adherent to medications. That might be where additional support, additional solutions not only can help patients stay adherent, but also give them the support of a nutritionist, of exercise coaching that that might be a financial barrier outside of benefits.
Yeah, and I would continue, Catherine, too, as we think about bringing in these other data sources like we've talked about today, we really can start to filter together those attitudes, those lifestyles, behaviors, all that about those members and their families. We really want to just better understand the risk factors between the communities so we can start engaging them. And as we talked today, we talked today about GLP-1 drugs. This applies itself across a continuum, whether we're looking at diabetes or we're looking at CAD or CHF, congestive heart failure. If we're starting to think about people and how they engage with asthma, what are those community barriers that they're encountering that we can actually have an impact on? And so, we brought to you guys today, some really cool data showing to you with the social vulnerability index, but there's a lot of other great levels of data out there that are publicly available. So we brought you just one last one here to show you. This comes from the Food Access Research Atlas that the USDA puts together. It's updated typically every 4 years, and it starts to look at how far away are people from a grocery store. So as you start to think about food insecurities, and how that plays a role in members' health and their families' health, how far away they are from a grocery store. And it takes that next step to even look at, urban versus rural, so we can really understand what are populations dealing with and how can we have an impact on them.
Yeah, so, and to that point, as you're kind of thinking about GLP-1 reporting, consider all of the data types that we talked about today and that you might need in the future. So, of course, beyond just prescription data and looking at utilization and spend on these medications, you might want medical data to look at off-label utilization. You might want to have access to biometric and lab data, so you can understand then both the baseline and outcome measures prior to the kind of downstream financial outcomes or downstream long-term clinical outcomes. The biometric and lab data will give you kind of that initial look into how your membership is doing on these GLP-1s. Weight management program data. I talked a bit about those support solutions. That's really critical to understanding if these patients that are taking these medications are making lifestyle changes in addition to the prescriptions. We talked today about socioeconomic data, but there's also HRA and health survey data. It gives us information into that attitudes and behaviors of good nutrition and healthy lifestyles. And then, of course, productivity data. That's a really important factor when you think about outcomes beyond just your clinical outcomes. The weight reduction and reduction of complications also can impact absenteeism and disability. So lots of different data sets to kind of think about as you're going to report on GLP-1s beyond just the prescription information. But that's all we have today. I know we covered a lot of topics, but we really encourage you to continue the conversation. What benefit strategies are you planning to deploy? How will you measure effectiveness, especially as it relates to socioeconomic cohorts? But with that, I think we're going to take a few questions.
Yes, we do have several already submitted. The first one I'll direct to Becky. Do we know why there is less utilization in union members? Is it related to coverage by their plan or prescribing habits?
So we don't know the why exactly. I would suspect that it's got more to do with the coverage than with prescribing patterns. Just because we wouldn't typically expect a provider to prescribe differently based on whether a member is part of a union or not, right? It's maybe not even something they're aware of. So because of that, I would say it's likely due to benefit differentials, plan design plan design differences between what's offered to the union and what's not. I don't know, Catherine, if you've got any thoughts on that.
Yeah, that's exactly. Most of the time, the provider themselves wouldn't necessarily, to Becky's point, that wouldn't necessarily know whether or not, this patient's in a union or not, but moreover would look at their benefits, understand, most of the times when providers, before they'll prescribe, they'll kind of try to get an understanding of if something's going to be covered, if not. And so that's more likely is that it is benefit design. It could be barriers to out-of-pocket costs, potentially, even if the medications are on formulary, maybe because it was, maybe decided in place a long time ago, to Becky's point about the kind of lag in union coverage, it may be that the out-of-pocket costs are quite a bit higher. And so they're selecting then medications that are a little bit more accessible financially.
Thank you. What advice do you have for payers to measure the effectiveness of diabetes management programs?
Yeah, I can take that one. So related to what's still up on this slide, the last slide that Catherine talked to. So one is just making sure that you have all of the right data, having your medical and prescription drug and anything else that you have access to. But I think really the most important part is having expectations going into it. So we look a lot at financial returns. Depending on when you're doing that program evaluation, you might not see a financial return. You might actually see increased costs. So if you're enrolling a patient with diabetes into a program and they're not adherent to their meds and they're not getting their foot exam or whatever other sort of recommended care they're supposed to be getting, and this program is now getting them that care, you're going to see short-term increased costs. So it's just knowing what to expect as you go into that program evaluation and saying, hey, in the short term, maybe the KPIs that I'm looking for are things like increased medication adherence, increased adherence to other sorts of recommended care. Maybe I might start seeing some decreases in ER visits, and then keeping sort of the longer term financial impact for a longer term analysis rather than right off the bat.
Thank you. The next question is, why are GLP-1s covered for weight loss since we don't know the long-term implications? The first studies are just coming out.
Yeah, so I can take this one. I'm going to go to a little bit of a timeline about GLP-1. So the original GLP-1s were approved about 20 years ago and for diabetes insulin management. But pretty early on, within the first maybe 4 or 5 years, weight loss was discovered as a beneficial side effect, a secondary improvement on these patients. And so actually the first weight loss GLP-1 was Saxenda, and that was approved all the way back in, I believe it was 2005, 2006, and someone can correct me. But it's actually been on the market for quite some time. And obviously there's been, Wegovy, for example, just came out a year or so ago. And so there have been expansions in weight management, but the original studies did occur quite some time ago. There is some long-term studies that are going on currently. I do agree there's a lot of unknowns in terms of, can a patient stop? Right now, a lot of the clinical outcomes are showing that if a patient stops these weight management medications, that they won't necessarily, that they'll gain back a lot of the weight that was lost. So there's a lot of studies still going on of exactly how long a patient could take it, and especially the safety of long-term taking these medications. But I will say Saxenda, like I said, has been on the market for quite some time. That was the original weight management medication. And just a quick plug, I definitely recommend taking a look at the white paper we put together, and that's hence the timeline that we did, and kind of walks through that as well. Yep.
There are some good resources we have available. Thanks.
Yep.
Do you have any examples of strategies or programs that payers have used to improve outcomes for diabetic patients in high poverty populations?
Take this one too. So this does kind of relate back to that additional support programs, or weight management programs, or however you want to label those, but the additional support programs as they relate to GLP-1s. Again, creating better access to nutritionists. So even if not a weight management program, if you are to make nutritionist visits more accessible to patients. I know some payers are looking at gym memberships, at exercise classes, but making those accessible as well for lower income patients, as well as encouraging the use of those, or in some cases, if you're going to cover, potentially putting the use of GLP-1s through those. So I know a lot of weight management programs now will assist with the coverage of GLP-1. So you'll need to go through that weight management program in order to gain access to weight management GLP-1s. And I want to emphasize this all weight management. For diabetes GLP-1s, we really don't want to create too many barriers to that, because again, the primary outcome for diabetes GLP-1s is specifically the insulin management. The weight loss is an additive benefit. So we don't necessarily want to create too many restrictions, because for some patients, those GLP-1s are going to be the best class for insulin management, not necessarily just because of weight loss. Again, that's added benefit. So just to split those up again.
Thank you, Catherine. Well, unfortunately, that's going to have to be our last word on this topic today. We are out of time. This does conclude the seminar. If we didn't get to your question, Merative will follow up with you offline. Thank you for joining us today for the webcast. I'd especially like to thank Brandy, Catherine, and Becky for being with us and sharing their expertise. And a special thank you to Merative for sponsoring this event. If you missed any part of the program, you'll be able to hear a recorded version within 48 hours on the EBN website, and we'll send you an email with a link to that recording. Thanks again for being with us and for the great questions and feedback, and have a wonderful rest of your day.